Good evening and welcome to this third educational webinar, Allergy Experts in Action, Alexa. This webinar is supported by Nutricia Specialized Nutrition. This webinar has been accredited as 1 hour of continuing medical education by Dubai Health Authority. Attendee certificates will be sent in the coming days. And since this is a CPD accredited event and as per the accrediting organization requirement, please note that credit certificates will be provided only to those who participated fully in the activity and completed its requirements. If a participant failed to attend this activity in full, then he will not be eligible to receive credit points assigned for that activity. The webinar will take the format of 2 individual presentations. These will be delivered by our guest speakers, and each presentation will be followed by a dedicated question and answer session. You have a chat tab that you can use, but please submit your questions using the question tab only. And you can see this tab on the right of your screen during the presentation. You can send your questions while the speaker is presenting, and at the end of his presentation, the speaker will reply to as many questions as the time will allow. To start the webinar, we would like to welcome our first speaker, Dr. El-Hodhod, for his presentation, Neocate Evidence in Management of Allergy. Dr. El-Hodhod works as a head professor of pediatrics in the Faculty of Medicine in Ain Shams University in Egypt. He is also the head of pediatric gastroenterology and endoscopy. His specialties are pediatric gastroenterology, hepatology, and nutrition international. It gives us great pleasure in welcoming Dr. El-Hodhod to join us for this event.
Good night, my dear friends and colleagues. I'm happy to be with you on this webinar activity, speaking about the amino acid-based formula evidence in the management of allergy, whether it is cow's milk or others. So, little about the suspicion and diagnostic criteria of the cow's milk protein allergy, then moving to the treatment and the prognosis. What are the clinical presentations of cow's milk allergy and when to think in? Let us take this question first. Clinical presentations of cow's milk protein allergy can be gastrointestinal alone, skin affection alone, respiratory affection alone, or combination of the above items. Please go through and choose the correct answer in your opinion, and this is usually dependent on your clinical experience. You can choose one or more answers, but in your opinion, which answer is the best? Okay, let us see. Actually, in the presentation, a combination of different system affection is the usual one. However, gastrointestinal manifestations isolated without any other affections can be there. Skin affection isolated without any other affection is a possibility. However, respiratory involvement alone cannot be the sole manifestations of cow's milk protein allergy. This is nice guideline, and in which you can see their classification of the symptomatology and signs of cow's milk protein allergy into IgE and non-IgE mediated disease. And they classified them into skin affection, gastrointestinal affection. And if you look here, you are going to see multiple symptoms and signs and the diseases that can be attributed to cow's milk protein allergy. The respiratory system can be also manifest in cow's milk protein allergy. Anaphylaxis or systemic allergic manifestations can be present. What does this mean? Why I put this in front of you? I meant here that many symptoms, many signs, many disorders can be present in cow's milk protein allergy. And in all these symptomatology, cow's milk protein allergy is a differential diagnosis. So just put in mind the possibility of cow's milk protein allergy when you meet these symptoms, signs, or disorders. Then move immediately, taking a focused allergy history and examination. And by focused history and physical examination, we mean good family history, not only for cow's milk protein allergy, but as well for other atopic and allergic disorders. Feeding history and which time he started his complementary feeding. Age of onset of the current symptoms presenting to you. Temporary relationship between the cow's milk protein intake and the occurrence of the symptomatology. Keep in mind that some of the IgE diseases may be seconds, and in the non-IgE, it may be weeks. Reproducibility on repeated exposure is very important. On physical examination, it's not expected to find a great deal. Usually, it's of little help. However, you should take the anthropometric measurements to assess the growth parameters. Some signs like atopic dermatitis may be there. And get sure there are no alarm signs that take you to other organic diseases other than allergy. These are called the red flags. Red flags usually need, when you found them, to refer the patient into higher care from the very early beginning and do not make the cow's milk protein allergy your first possibility. These include significant GI bleeding, significant underweight, significant abdominal distension, metabolic derangement like acidosis or something, neurologic affection like seizures, severe presentation in breastfed infants, association with fever, abdominal tenderness, organomegaly, or severe pallor. And because after taking this history and suspecting from the NICE guidelines by the presentations, you need to have some high suspicion index. COMIS was introduced for this purpose. COMIS includes crying with a maximum of 6, regurgitation with a maximum of 6 marks, bowel habit with a maximum of 6, skin involvement with a maximum of 12, respiratory with maximum of 3, then you have 33, and if you got score of 12 or more, you can suspect. Still, you have high suspicion index, but it's not a diagnosis. It's clear. It is a suspicion index. With some exceptions, they cannot fit. They cannot be suspected or omitted based on the COMIS score. COMIS cannot be applied. For examples, we are going to see this later. This is the scoring system for crying from 0 to 6. And this one for regurgitation, it is between 0 and 6. And because stool character is very important in this score, they depend upon the Bristol stool scale that classified into types. Constipated types will be 1 and 2. Normal is 3 and 4. Diarrhea is 5, 6, and 7. According to the severity of diarrhea. Here, the score will differ. Whether it is constipation, they took 4, normal took 0, 0, mild diarrhea will take 2, moderate diarrhea will take 4, and severe diarrhea will take 6. Skin manifestations are divided into either eczema or urticaria. Urticaria is all or none. If there is urticaria, it's 6. If no, it's 0. Eczema is divided between extremities, head and neck, and from 1 to 3. So eczema in whole is of maximum 6. Respiratory varies according to slide. Will take 1, mild to take 2, severe to take 3. And this is usually a rough estimate. It's not very difficult to assess. So please take this question. COMIS is awareness tool, diagnostic tool, prognostic tool. Please choose the correct answer in your opinion for this score. Yes, it's okay. Awareness tool, it is the answer, the main answer. So, as we said before, it's not a diagnostic tool. COMES is not a diagnostic tool. For the last time, COMES is not a diagnostic tool. Sometimes in research, we can use it as prognostic tool as well. In practice, actually, improvement is very clear in sharp cases, and you are not in need for a COMES score to say this person is improving on cow's milk elimination. So, what would be the diagnosis of cow's milk protein allergy? Go to this question, please, and choose your answer. The gold standard of diagnosis of cow's milk protein allergy is total serum IgE, allergen-specific serum IgE, skin prick test, patch test, elimination rechallenge test. Please go and choose your answer. Very tricky? No? The gold standard in the diagnosis of cow's milk protein allergy and any other food allergen is elimination rechallenge. And others are of limited use. So sometimes in IgE-mediated severe disease, we may need to have this document of positive serology or skin prick test for this specific allergen, but it's usually clear that you cannot need, or you do not need this test to have the results of this test. In severe anaphylaxis, COMES cannot be applied. And as well, there is no rechallenge in anaphylaxis. If there is anaphylactic reaction occurring on exposure to milk, and you have taken milk off and symptoms disappear and everything is okay, you do not need to have this rechallenge. I will give you one story. In one occasion, the grandmother came to me saying, okay, dear doctor, you have diagnosed my grandson as cow's milk protein allergy anaphylactic type on the assumption that he was about to die receiving his bottle. And I said, yes, it's clear. It does not need any other test. This is very sharply defined. And she said, okay, doctor, do you know, I gave him the milk with the spoon and he didn't react. And actually, this was latex allergy and not cow's milk protein allergy. Keep in mind this possibility before diagnosing cases receiving the bottle as cow's milk protein allergy. Anything, even contamination with protein milk, should be avoided completely during elimination. And the duration of elimination in the diagnosis, not in the treatment, it is usually between 2 and 4 weeks, and it shouldn't be less than 2 weeks, and usually you don't exceed 4 weeks. If anyone, we eliminated the milk for 4 weeks and he didn't respond, this is not cow's milk protein allergy whatsoever. If no improvement occurs after 4 weeks of elimination, please refer for further diagnosis according to the symptomatology. If it is gastrointestinal, send him for a gastroenterologist. If it is skin manifestation, please send him to a dermatologist. A few days ago, I was met with one who is diagnosed as eczema, and they stopped the cow's milk for the last 2 months without any improvement, and actually on examination of the case, this was a case of psoriasis, not eczema. Precautions when asking for allergy test. Do not carry out allergy testing without first taking an allergy-focused history. We are not screening with this test. We are taking history. There are symptoms, there are signs. We take history and we apply the awareness tool, and then we suspect, and then we do the test. Whether this test was a blood test, it is a patch test, or even elimination challenge. Enter the results of the tests if you are getting these tests in context with the allergy-focused history. Please do not ask for IgG test. Again, no IgG test in the diagnosis of food allergy. Moving to treatment. It's clear by Esbigen and NICE that strict avoidance of cow's milk protein is the safest strategy for managing cow's milk protein allergy. What are we going to do when he is breastfed? Okay, just go to the mother, ask her to stop milk and dairy products strictly, and she will continue breastfeeding as the main line of feeding for this kid. Please, some of the mistakes is stopping breastfeeding in this condition. This is a crime. What foods we are going to avoid? Milk and dairy products. Usually it needs a qualified dietary counseling because some hidden antigens may be there. This is according to the Esbigen. Some cow's milk and beef in 10%, cow's milk and goat milk in 92%. So I think goat milk is not an alternative in cases with cow's milk allergy. Regarding beef, because it's only 10%, some of the authorities will say, okay, let him take beef, and if there is reactions, stop it later, but do not make it as a general rule to stop beef. With mare, it is for mare milk, it's only 4%, so mare milk may be an alternative in cases with cow's milk allergy. Other milks like almond or other alternatives are actually not milks, they are mixtures of some calories, and actually they cannot be nutritionally sufficient. We do not recommend them as milk substitutes. Industrial juices made of soy, rice, anything else are actually deficient in their nutritional requirements. Let us move to this question, please. Being cow's milk protein allergy, goat milk is safe? True or false? Now you have the answer from the previous slides. So, okay. You said, it's false because goat milk is cross-antigenic with cow's milk in 92% of the conditions. And actually, in addition to this cross-antigenicity, it is deficient in vitamin B12 and folic acids. So we are not going to replace with goat milk. Take this question, please. In formula-fed infants, elimination test can be achieved by using extensively hydrolyzed formula, partially hydrolyzed formula, amino acid-based formula, soy-based formula. Please choose for this elimination test. I'm going to eliminate before we challenge. And he is formula fed. What other food I'm going to give him during this period of elimination? Okay. Have you taken your time? Have you finished your voting? Let us say it is amino acid based formula only, because although extensively hydrolyzed formula may be prescribed in cases with cow milk allergy, and in most of the guidelines they are prescribed. However, because of the possibility of about 5 to 10% cross-antigenicity or having some residues of antigens, they cannot be an elimination diet. Of course, partially hydrolyzed formulas are absolutely contraindicated in this context, and they are absolutely contraindicated even in treatment of cow's milk protein allergy. Soy-based allergy, there is a cross-antigenicity, not antigenicities. 30% of the cases with cow's milk protein allergy may be soy allergic as well, and their use may yield manifestations of allergy, and by that time you cannot diagnose the cow's milk protein allergy. Is milk remedy different according to the clinical context? Amino acid based formulas. So In this slide, you can say that amino acid-based formula is suitable for cow's milk allergy, and it is also suitable for symptom relief in multiple food allergy. Evidence base also supports other allergy-related indications like eosinophilic GI disease. Other diseases include atopic dermatitis, gastroesophageal reflux disease, eosinophilic esophagitis, short bowel syndrome, and other gastrointestinal conditions. Hypoallergenic formula is the gold standard, and any formula to say it's hypoallergenic should pass the appropriate testing demonstrating it does not provoke reaction in 90% of infants or children with confirmed cow's milk allergy in a prospective randomized double-blind placebo-controlled trial. This is the American Academy of Pediatrics and ESPGHAN guidelines. 100% of amino acid for infants 0 to 12 with LC-PUFA nutritional profile in line with the latest guidelines. It's the gold standard, amino acid based. It ensures fast and effective relief of cow's milk allergy and gastrointestinal symptoms within 3 to 14 days, regardless of complexity of the situations. It's made of 100% amino acids and contains 0 residual peptides derived from cow's milk. Within 14 days on amino acid formula, most of the manifestations of cow's milk allergy in GIT will disappear. However, in 3 days on amino acid formula, significant improvement will occur with atopic dermatitis and other non-cutaneous manifestations that are including vomiting and diarrhea. The question is, use of amino acid-based formula in the dietary management of cow's milk allergy. When is early intervention with amino acid formula the right approach? In IgE-mediated disease, in anaphylactic reaction, according to the DRACMA study, anaphylactic diagnostic criteria include sudden onset involving symptoms of the skin, mucosa, or both with at least one respiratory symptom. Non-IgE-mediated disease, children with growth failure, persistent atopic dermatitis, and or severe systemic or GI symptoms will benefit from the amino acid formula as the first line of treatment. If you are starting, in some cases, extensively hydrolyzed formula and the symptoms did not resolve, this represents 2 to 10% of infants with uncomplicated cow's milk allergy and up to 40% of infants with more complex allergies. Persons can show reaction and intolerance to extensively hydrolyzed formula. In this condition, you don't have any alternative. It's only alternative to shift to amino acid-based formula. Moderate to severe allergic reactions, it is a dietary, good dietary remedy because amino acid-based formula will help a lot. It's well tolerated in children who are allergic to cow's milk and may be safer than extensively hydrolyzed formula. And here you can find that mild symptoms appeared with Neocate. Other extensively hydrolyzed formula, it reached about half of the cases, like in notrimagine, having the reaction to cow's milk intake. This is regarding safety and tolerance to the use of it. In another study on 16 infants with adverse reactions to cow's milk, 9 infants on extensively hydrolyzed, other had a diversified diets. In atopic dermatitis score, intestinal permeability and weight were assessed. Amino acid was given for 1.5 months, and these score for atopic dermatitis, intestinal permeability, and weight were repeated. All infants gained weight, had disappearance of symptoms of atopic dermatitis, and the hyperpermeability of the intestine improved in 80% of the persons. Improved that was shown in extensively hydrolyzed was improved on amino acid based formula. Amino acid based formula, and here the manifestations of with amino acid, and you can see how much the improvement is. In 28 infants with persistent cow's milk symptoms who were unresponsive to extensively hydrolyzed formula, amino acid formula was the sole source for nutrition for 2 weeks. 25 over 28 had significant symptom resolution with partial improvement in the remaining 3. And this is a very good test that demonstrates that in failure of extensively hydrolyzed, you can shift immediately to the amino acid based formula. Regarding growth, comparison between extensively hydrolyzed and amino acid based formula with atopic dermatitis and cow's milk allergy, follow up in 9 months. Growth and severity of atopic eczema were determined. Both formulas were effective in treatment of atopic eczema. However, growth was significantly better on amino acid based formula. So we can say that amino acid based formula will promote normal growth. And you can see here that Neocate as amino acid based formula will achieve relative weight better than hydrolyzed formula. And here is the relative length. It's better with the amino acid base compared to the extensively hydrolyzed formula. In double-blind challenge tests in 73 infants with atopic eczema, divided between 2 groups, extensively hydrolyzed and amino acid based, and monitored over 6 months, both formulas were effective in treatment of eczema. A small significant improvement was noticed in length in the group of amino acid based formula. Here, Neocate in red achieved better improvement than extensively hydrolyzed formula. Eosinophilic esophagitis, which is a chronic condition with eosinophilic infiltration of the esophagus caused by foods. Eosinophilic esophagitis is increasingly diagnosed in pediatric population after being recognized in adult population. Chronicity, and especially in males, with food impaction, swallowing problem, reflux, weight loss, poor nutritional status. It's actually those who are working in gastroenterology knows well that this is a problem, significant problem. In this study, previously diagnosed with gastric reflux disease that is not responding to anti-reflux therapy, they were put on amino acid based formula for a minimum of 6 weeks. Complete resolution occurred in 8 children and significant improvement of symptoms in 2. Eosinophilic count and the epithelial mucosa improved significantly. And here you can find the esophageal eosinophilic count before and after use of the amino acid based formula in eosinophilic esophagitis. It is clear by this decline of the number. Patients serious with chronic gastroesophageal reflux symptoms and isolated esophageal eosinophilia can be put on proton pump inhibitors, and after 3 months, those who are not responding were diagnosed as eosinophilic esophagitis, and they were put on the amino acid based formula. Their vomiting, abdominal pain, and dysphagia improved significantly. Use of amino acid based formula in esophagitis, and here you can look at this pre-test and post-test, and you'll find that all symptoms are improving with the exception of chest pain, night cough, and irritability that were not significantly different. However, eosinophilic count, abdominal pain, vomiting, heartburn, water brush, and the globus feeling as well as dysphagia improved significantly. It's very helpful. Eosinophils before and after, GERD symptoms before and after, and dysphagia symptoms before and after. So, clinically proven to be safe, amino acid-based formula has fast effect, and multiple in cow's milk protein allergy and in multiple food allergies. It meets the recommendations by the American Academy of Pediatric and the SPGAN guidelines. So we can say, frankly speaking, it's a gold standard in cases with amino acid-based formula is the gold standard for treatment of cow's milk allergy and multiple food allergy. Only American Academy of Pediatric approved hypoallergenic formula such as amino acids and extensively hydrolyzed should be used in dietary management. And by this, I mean no place for other formulas, no place for partially hydrolyzed formula in treatment. None of the current international cow milk guidelines recommend soy or extensively hydrolyzed rice formula in the first-line management of cow's milk allergy. Extensively hydrolyzed are recommended in first-line management of infants suffering from cow's milk allergy. Amino acids formula are recommended when symptom resolution fails after elimination diet using the extensively hydrolyzed formula. Amino acid formula are recommended as first-line management of patients suffering from eosinophilic esophagitis. And here you can see this table with anaphylaxis, FBIs, and eosinophilic esophagitis as having amino acid-based formula as the first line of treatment. And if other indications occur for the extensively hydrolyzed formula, when they fail, you are going to move to the amino acid-based formula. When to refer, if there is an acute systemic reaction, if there is severe delayed reaction, faltering growth, significant atopic eczema with multiple foods causing intolerances, those who have not responded to single allergen elimination, those with asthma who have confirmed IgE-mediated food disease, those in whom there is strong clinical suspicion of IgE-mediated disease but allergy tests are negative, persisting parental suspicion of food allergy in spite of your elimination, clinical suspicion of multiple food allergies according to NICE guidelines, these should be referred to allergologists, gastroenterologists, and nutritionists. We are at the end. Cow milk allergy is a common encounter in pediatric practice. Clinical presentation is very diverse. Not thinking or suspecting means missing many cases and underdiagnosis. However, overthinking and rushing without precautions means delayed diagnosis of mimickers. The gold standard in diagnosis is elimination rechallenge. Pitfalls of this technique are a lot and may be subjective. So if not sure, get a specialist opinion. Referral based on red flags may save the life of your patients. In formula-fed elimination, testing is better achieved by amino acid-based formula. For treatment, breastfeeding with maternal strict elimination is the rule, and in formula-fed infants, define your diagnosis to choose the formula. Amino acid-based formula is very safe and very effective. And thank you.
Thank you so much, Dr. Al-Hudhud, for that educational session. We would like to move swiftly on to our second and final speaker for this evening, Mrs. Dima Abu Saleh, and her presentation, How to Practice Weaning with CMA Patients. Mrs. Abu Saleh is the head of the Nutrition Service Department in King Faisal Specialist Hospital and Research Center in KSA. Again, it gives us great pleasure in welcoming Mrs. Abu Saleh to join us this evening.
Hello everyone, my name is Dima Abu Saleh. Today I will talk about how to practice weaning with cow milk allergy patients. Food allergy and food intolerance prevalence has almost doubled in the last 20 years with a defined increase in severity and scope. In children, since the 90s, we had four-fold increase in food allergies. Food allergies goes under an umbrella called adverse food reaction. It has two types: food intolerance, which is an adverse reaction to a food caused by toxic, pharmacological, metabolic, idiosyncratic, or non-immunoglobulin E reaction to food or chemical substance in the food, while food allergy or hypersensitivity is an IgE-mediated reaction that occurs when the immune system reacts to a normally harmless food protein that the body has mistakenly identified as harmful. It occurs within 2 hours. This is a very important point. Symptoms, it's a wide range. It affects skin, respiratory, cardiovascular, or gastrointestinal. But the most serious one is the anaphylactic shock. It's an acute, often severe, and sometimes fatal immune response. Occurs within a limited time following exposure of an antigen. Systemic anaphylaxis is the most dangerous allergic reaction. Usually we ask the family to have an epinephrine with them just in case a reaction happens, they would be ready to react. The risk factors for development of food allergy has several ones. One of them is heredity, like if the parents have allergy history, the baby may get it. Other siblings, the baby may get it. Exposition, it has several points. First, late introduction or avoiding of high allergenic food. So late introduction of food or hypoallergenic food may increase the risk of food allergies. Industrial manufacturing of food, this is a theory saying since we've been exposed to a lot of processed food, our system reactions to this food is different. Changing in our eating habits from eating natural kind of food to mostly processed, genetically modified or whatever kind of new food industry. GI permeability is related to this. They're saying the food industry is increasing our GI permeability, which will lead or increase our risk of food allergies. Environmental factors include microbial exposures, like if you have an infant who's developed gastroenteritis, he might develop a secondary cow milk allergy. The other one is lifestyle change, which lead to less introduction to microbia, normal flora. So babies or infants is having less normal flora than before. And this is positioning them in a higher risk for food allergy. Increased C-sections. There's a link between normal flora and increase and C-sections. And there's a study showing that babies born as C-section or through C-sections have a higher increase risk of or high numbers of food allergies than normally delivered babies. Common food allergies, the most common ones are cow milk allergy, egg, peanuts, tree nuts, soy allergies, wheat, and fish. And the treatment of food allergies, as we all agreed and Dr. Hudhud mentioned, is the first thing is to eliminate or remove the food allergens from the diet. The second one, since we remove this food, we need to replace it with something or alternative to help provide the nutrients missing from that kind of food. Finally, we need to make sure of nutritional adequacy of the diet. We need to monitor it on regular basis in order to make sure the baby is growing well and receiving the nutrients needed. Now we will talk about cow milk allergy. Cow milk allergy is one of the most commonly reported childhood food problems. It is the leading cause of food allergy in infants and young children younger than 3 years old. The prevalence of protein-induced enterocolitis is also high. It's around 0.34% with distinct clinical presentation of that of IgE, cow milk allergy. So even food protein-induced enterocolitis is common. In this table, I'm just sharing with you the differences between the IgE-mediated and non-IgE-mediated. Dr. Hudhud mentioned the difference in symptoms. Here, I just want to discuss The time of exposure to reaction for the IgE mediated, it's minutes to 2 hours, while non-IgE mediated, it go up to 2 days. 2 days, not 2 days, 2 days. Severity, IgE mediated, it goes from mild to anaphylaxis. For the non-IgE mediated, it's mild to moderate. The duration for the IgE mediated may persist beyond 1 year. For non-IgE mediated, usually resolves in 1 year. We're talking here about cow milk allergy. Diagnosis for the IgE mediated, specific serum IgE and skin prick test, while for the non-IgE mediated, it's the oral challenge. Here I have a question. The first question, in your practice, what do you recommend for breastfed infants with cow milk allergy? So the baby is diagnosed to have cow milk allergy and the mother is able to breastfeed him. What would you recommend? To continue breastfeeding, with mother elimination diet, extensively hydrolyzed formula, or amino acid-based formula? Dr. Hudhud discussed this point, so I'm waiting for the answers. The correct answer would be continue breastfeeding with the water elimination diet. And thanks to Dr. Hudhud, he discussed the elimination diet and how the mother should even eliminate or avoid food that may have cross-contaminations with cow milk. Another question, if the baby is diagnosed with cow milk allergy, what would be your formula recommendation? Is it extensively hydrolyzed formula, amino acid-based formula, soya-based formula, milk of other mammalians? The answer would be depending on the severity. Like if it's a severe cow milk allergy, the first option would be extensively hydrolyzed. If it's a regular cow milk allergy, if it's a severe case, it would be amino acid based. But for regular cow milk allergies, we would recommend extensively hydrolyzed cow milk formula. If not tolerated, we will go to amino acid based formula. Soya based formula is not recommended at all, and other mammalians milk is not recommended. When do we have amino acid based formula as our first options? When there is a severe symptoms. So we will stick into amino acid based formula. What is not recommended for the management of cow milk allergy? Partially hydrolyzed cow milk is not recommended. Soya formula for babies or infants below 6 months or at any age with GI symptoms. Goat, camels, and sheep milk protein, unmodified soy or rice milk, milk beverages based on almond, rice, coconut, all of those are not a full nutrition. It's only a drink and should be avoided to be used as a source of infant formula. Management of cow milk allergy, again, it's the same like any other food allergy. First thing is to eliminate the milk from the baby's diet, educate the parents of the allergen and how to avoid it, ensuring optimal nutrition and body growth by following the baby continuously by the dietitian or the pediatrician. Then we have reassessment every 6 to 12 months after the baby reach 1 year old for reintroduction of cow's milk protein. So when the baby reach 1 year, I will start reintroducing the milk. Weaning diet for infants with cow milk allergy. What is weaning? Weaning is the process of gradually introducing complementary food to the infant diet when breast milk or formula is no longer sufficient to meet the nutritional requirements of infants. It is very important because we are teaching the baby how to eat their adult food, moving from milk to their adult food. So it has a very important developmental and nutritional and growth benefits. Introduction of the appropriate food at the appropriate stage of development is a prerequisite to the infant's optimal growth and health. The main purpose of my introduction or solid introduction is to provide the needed nutrients and help the baby to develop well. So I want him to have the needed nutrients because the milk, especially the mother milk, will not be sufficient at 6 months of age, after 6 months, and to help the baby develop well. I have a question here. In your practice, at what age you recommend the introduction of complementary food? After completing 6 months, between 4 to 6 months, at 5 months of age, and it depends on the case. What is the answer? I will hold the answer also and ask this fourth question because both of them I will answer them together. In your practice, at what age do you recommend the introduction of an allergenic food like fish, egg, peanuts? When do you recommend the introduction of that food? After 6 months, after 12 months, after 10 months, or it depends on the case? Actually, the new recommendation, I grew up learning that we should do only exclusive breastfeeding until the baby reaches 6 months of age. But the new studies showed that earlier introduction of complementary food is even better. And most of the international organization is recommending the start between 4 to 6 months. ESPGHAN, they are saying the start would be after 17 weeks and no later than 26 weeks, saying you should not delay the introduction. Timing depends on individual needs and developmental readiness. What do we mean by that? The babies are different. So some babies are ready at 4 months, others are ready at 5 months. Mostly healthy, well-nourished baby will be ready at 4 months. But I teach the mother usually to look into some symptoms, especially when dealing with sick population or sick infants. Like in my hospital, it's a tertiary hospital, so most of babies would have other problems. So I will tell the mother to monitor the signs and symptoms of readiness for this baby to start the solid. One of the symptoms or signs, not symptoms, that he would be able to hold his head when he is laying down in the baby clothed chair, the one that is a very soft chair. The other one that when the mother is eating, he's actually looking into the food or the spoon. One of the things that he started putting his finger in his mouth or putting toys in his mouth. So monitoring those things would let the mother know that the baby is ready to start oral or let's say solid introduction. Introduction of potentially allergenic foods such as eggs, wheat, and peanuts should not be postponed beyond 4 to 6 months of age. So we should actually start. As we start the weaning diet, we should start the allergenic, potentially allergenic food. Delaying the introduction of those allergenic food has no proven benefit to affect the allergy prevention and should be avoided unless there's a proven allergy to any of them. Before, we've been delaying the introduction, saying that this will reduce risk of developing allergies in the future, but this seems to be the opposite. Actually, delaying the introduction is increasing the risk of developing food allergies. We all need to be safe when introducing complementary food to infants with cow milk allergies, and those are some tips to look at. First, introduce single ingredients food, one at a time, and wait for 3 to 5 days before introducing a new food in order to find out or monitor any allergic reaction. You need to instruct the parents to look for any allergic reaction like rashes, atopic dermatitis, vomiting, diarrhea, redness. Some babies will develop redness around the lips. Any signs like that would alarm them to stop that food immediately and not to give more. We need to instruct the mother on clear steps to follow in case of an allergic reaction to food. We also recommend to introduce a new food early in the morning Just in case the baby developed any reaction, the mother would have time to do the necessary action, like take him to the hospital, give the medication. If I introduce the food at night and the baby develops something late, it would be difficult to handle. Complementary food should be cow milk protein free for sure, until a supervised successful oral challenge indicates the development of tolerance. So the parents should not introduce any cow milk protein until it is introduced in a safe environment and monitored way. Complementary food introduction, also we need to discuss what to start with. The recommendation is to start with cereal for normal babies. If he's a baby with cow milk allergy, I would recommend iron fortified milk-free baby cereal. The recommendation is to give this cereal in a thinner way as a startup. So we will put 1 tablespoon of cereal with 4 tablespoons of breast milk and the milk the baby is taking, and mix it. This will make it very thin, similar to the milk the baby is taking. So we will teach him or we will introduce something that he's familiar with, but should be introduced by a spoon. And the mother should resist the temptation to give this by a bottle, because one of the reasons of introducing complementary food is to teach the baby to eat by spoon. It needs different muscles that needs to be developed. So as you know, the process or the mechanism of swallowing liquid is different than the mechanism of swallowing more thickened food. So we will start with the cereal 1 to 2 times, very thin, and then every day we will start making it thicker until we reach the optimal thickness of a yogurt. It should not be lumpy, but it should be soft like a yogurt. Can be given to the infant 1 to 2 times a day. Then we will start trying the puree vegetables or fruits. Vegetables should be one kind. If he tolerated, let's say we start with zucchini. So he tolerated the zucchini well, then I can add to the zucchini carrots. And then it would be carrots and zucchini for several days. Then we will start introducing the new item. We should never, ever introduce 2 new food at the same day. One of the recommendation or advices I give the mother is to boil the vegetables with little water, in order that when she's going to mix it, not to lose that water or drain it, because most of the minerals is launched into the water. So if I'm going to throw this water away, I will lose a lot of minerals. Meat, chicken, legumes, and eggs should be introduced to the baby within the first few months of complementary food introduction. The texture progression of the feed is very important. We need to advance with food texture. It is important for the baby to develop, including speech muscles. So if you delay the progression and you keep giving your baby puree, that will make delay their speech. It teaches the baby to accept new food later in childhood, and this is something known that or proven that delayed progression of textures or delayed introduction of solid may lead to have picky eaters. The first food, as we said, is puree. We don't need to put a lot of water. We need to teach the mother to use the water the vegetables have been boiled in, and then blend it in the blender. This is 4 to 6 months of age. At 7 months, the baby can tolerate some lumpy food, so they will mix it using the blender, but they will keep some lumpy food, so the baby will learn how to move his tongue and start to chew a little bit. At 8 months, we will provide finger food, but it has to be a soft food, and look at the baby and monitor them when we are feeding them. After that, we will move to the mashed food. Mashed food by spoon or a fork between 2 to 12 months, like vegetables and everything, we will smash it, including meat. At 12 months, we will provide crunchy and crispy. I don't mean by that very hard food, no, but a little bit the baby can start to chew in order to again move their tongue. After 18 months, we can start giving chewy food. Before that, the baby will not be able to tolerate it. What to avoid? This is generally for every infant. We need to avoid popcorn, whole nuts, raisins, and whole grapes. Why? To reduce the risk of choking. Whole nuts, we cannot give that to them, but we can give them crunched or like peanut butter. We can start giving it them. We should not give them small things that could stick in their throat, or they will be having a choking risk. Hard and food pieces, like giving crackers, hard crackers, or hard biscuit that they cannot soften by their mouth. Sticky food also need to be avoided. Concentrated sweet, canned vegetables, because it contain additives and high in salt. Some families ask me about frozen vegetables. Frozen vegetables is fine. Canned vegetable do not include baby food, because baby food, it's air sealed, do not contain additives or salt. Honey, to reduce the risk of botulism. For cow milk allergy infants, we need to have more avoidance. We need to avoid any product that may have yogurt, cheese, or butter. Goat and sheep cheese, we need to be avoided. Last week, one of my friends, she asked that one of the physicians told her baby has cow milk allergy and he's 1.5 years old. He told her you can try other kind of cheese like goat cheese. And I asked her not to do that. Why? Because of the cross reaction. Common food which contains cow milk, like chocolate, margarines, sausage, biscuits, all of them contain milk in it. Hidden milk, like in cooked meat, burgers, if you're buying burgers, pate, chicken, processed chicken, chicken nugget, lentils, but it's cooked already. Unlabeled food, not to buy food that don't have a very clear labeling. The mother should not give her kid any food before reading labels. We teach them to read labels. And finally, read the ready food, like eating outside in a restaurant. Even if you are providing something that you're sure is not milk or milk product, you do not know the cross-contamination. You don't know where this food exposed to cow milk protein or not. So it is better under 12 months to avoid this kind of contamination. Feeding an infant with cow milk allergy is actually a challenge. Providing food or diet that is cow milk protein free would lead the infants to receive less calorie, less calcium, and less micronutrients, since many of the weaning foods contains cow milk, like zabadi, mahalabiya, cooked rice. A lot of things could have contamination. Most studies have found that children with food allergy have lower growth parameters than general population. In particular, height or age seem to be negatively impacted in food allergy. Children with multiple food allergies, cow's milk allergy, and atopic comorbidities, in particular atopic dermatitis, require particular attention for growth disorders. Prevalence of feeding problems in children with GI allergy is actually higher in general population. It's 30% of babies with cow milk allergy, while versus 17% for normal population. It's always important to ask the parents if the baby has any feeding difficulties, because early recognition of this problem will give us time earlier to act and to avoid having an effect of this difficulty on the future eating habits of the baby. Parents usually been offered multidisciplinary support, including speech therapy, psychology, and dietetics for the management of feeding difficulties. Speech therapy, like if the baby develop a gag reflux, whenever you're going to start solid and you're giving a baby something, he will vomit. But that vomit do not come from the stomach. That gag reflux, it comes from the throat. It's a reaction the baby is doing to avoid eating or drinking, because he linked this to pain or vomiting or an old symptoms that he or she need to have. Some risk factors will increase the feeding difficulties and will have adverse results, like maternal anxiety for allergic reaction. Mothers who have babies with food allergies or cow milk allergy who suffered for some times and finally they settle down, they are tolerating their milk, their, let's say, atopic dermatitis improved, their diarrhea improved, they start gaining weight, they become afraid to try any new food. They said, okay, my baby is finally stable. I don't want to go through this road again. I'm fine. I don't want to introduce it. And they start delaying food introduction. This delay will definitely have a negative effect on the baby. Symptoms like GERD, most of the babies may have GERD, swallowing difficulties, diarrhea, vomiting, or pain. This will lead the baby to have a link between food, milk, and pain or discomfort. And that may lead to reduce their appetite. They don't want to eat anymore. So the mother will come and force feeding. They will force them to eat. This force, as you know, will either make the baby vomit at the end or will limit the intake. Also, symptoms may lead to deterioration of feeding behavior. Babies will not like food as it should be. My daughter, she used to have a severe GERD, and whenever she have milk, she started crying. After that, she linked this formula or bottle to her pain, so she refused milk at all. She was refusing to drink milk and I used to feed her only when she was asleep, because whenever she's awake, she will refuse milk until we start the introduction of solid, and she likes solid. She started growing well. Dietary changes or changing in the baby's diet. Some mothers would have really bad eating habits, and that will reflect on their kid. Like they are finding that baby's taking milk and it's easier, okay, so no need to introduce solid. Or the mother would try this food today and see that the baby is not taking it, so okay, no need to do it more. Or she's having a very limited diet. I mean, just giving rice or just giving one kind of food and only one time and not progression. All of those may lead to low intake of formula if the baby is linking it to pain or he has severe symptoms. This would limit their food options also. Limiting the food option may affect the micronutrients and lead to micronutrients deficiencies, weight loss or slow weight gain, and finally faltering growth. Here it comes to a study about the use of yogurt type amino acid based formula. It's an open label multi-centered study. Infants and young children 6 to 36 months with diagnosed cow milk allergy with severe symptoms, okay? First, we gave the babies amino acid formula for 1 month before starting the study. And we had two groups, or they had two groups, control group liquid Neocate, test group liquid Neocate plus Neocate spoon. The duration of the study is 28 days. The outcome measure nutritional and energy intake, cow milk allergy associated symptoms, tolerability, and anthropometric measurements. The study had been done by Biot et al. The design this is the study design. 34 patients enrolled, two groups, 17 for each, but we had some withdrawals due to symptoms. So we ended up with 15 that completed group 1 and 17 completed group 2, and 1 did not complete the symptom questionnaire, so he's been out of the study. The results, the combination of cutaneous, GI, and respiratory symptoms are similar, so they've been both of them effectively having the same results or symptoms. Here we'll look into the tolerability. Both groups have the same tolerability. but the difference come to calcium. Look into the calcium in group 1, which is the Neocate with Neocate spoon intake is higher. Here we can look into the catch-up growth, weight for height, weight for age, and then we look into the body mass index for age, height for age. All these scores, all those kind of these scores had been shown higher in first group, which is the Neocate liquid and the Neocate spoon. Here I thought to put a portion size and delay intake just to teach the mothers that they can provide enough nutrients even for babies with cow milk allergy. Like between 4 to 6 months, they can take the milk-free cereal 1 to 2 tablespoons twice a day. They can start giving the fruit puree. It's the same. They will take the fruit and put it in the blender. They can add to it baby juice, very small amount, or mother milk or their milk. Except for the apples, they need to to cook it a little bit before mixing it to do an applesauce. Cooked puree vegetables, also 2 to 3 tablespoons. When the baby reaches 6 months, he can have the same milk-free cereal, oatmeal with milk substitute. I always ask the mother to use the baby milk in cooking their baby food or cooking things for this food, like oatmeal. We can start introducing eggs, fruit puree, cooked puree vegetable. It is not really recommended to introduce juices. Fresh vegetables, fresh fruits that are blended is better to teach them to eat fruits, to benefit from the fibers, and not to teach them to have juices. It's not really recommended anymore. Between 8 to 12 months, the baby will be introduced to everything, almost everything, meat, beans, he needs to have cooked puree vegetables. They can mix it together as soup and have it twice a day. Rice cup. And when they reach 8 to 12 months, they would have 3 major meal or main meals with 1 snacks in between. If we look into cow milk allergy prognosis, it's actually good. The duration of exclusion will depend on the age of the baby, the severity of the child's symptoms, and positively of specific IgE. At 12 months, this is a study by Shoemaker that at 12 months, 69% tolerate cow's milk. IgE-mediated cow milk allergy would improve by 57%, while non-IgE-mediated cow milk allergy will improve by 100%. Most of patients with food protein enterocolitis syndrome recover at 12 months of age. Some of them might be converted to IgE cow milk allergy, but mostly they are recovered. At 3 years old, children with 75% of them will tolerate milk, while at 6, 90% will tolerate milk. Here's something interesting that studies showed that many children can react, who have reactions to fresh milk, cheese, or yogurt, may tolerate baked milk or cooked milk, especially if it's mixed with other food or with flour, which make the milk less likely to cause allergic reactions. So if you have babies that have a reaction to fresh milk, cheese, or yogurt, they may be able to tolerate baked milk, especially with flour or other food. And I have a cow milk intolerance. I cannot tolerate milk or cheese, but I'm able to take baked food, like I can take cake, cookies, or anything that have milk cooked in it. Here I have the IMAP milk ladder. The IMAP milk ladder is developed by the British Society for Allergy and Clinical Immunology to provide a guidance for gradual reintroduction of milk in the diet. So we want to reintroduce milk in the diet, but we need to be careful and start introducing it slowly. It is recommended for infants and children with non-IgE mediated cow milk allergy. How to start? They recommend to start with small amount of baked milk protein, such as biscuit or cookies. Why? Because when preparing cookies or biscuit, you would need very little amount of, or it contain very little amount of milk protein from the butter and maybe a little bit of milk. So this is a small amount of baked milk, and we will see if the baby is tolerating it or not. And as we said, we will start after reaching 12 months of age. Okay, if this baby tolerated the biscuit, we will move to the next step after a few days. At the beginning, we will start, like if we're talking about the cookies, we will start a quarter of a cookie and then half a cookie. The next day, maybe we will give a full one and see if there's any reaction. After a few days of presenting this and we feel that the baby is able to tolerate, we can move to a bigger amount of baked milk, like a muffin. In order to bake a muffin, you need more milk than baking a cookies. So if, again, you will give small amount and then you will increase and build up until he finish one. If he's able to tolerate, we will move to the third step, which is pancake. Pancake will have more milk because, as you know, in preparing it, you will add a lot of milk. If it's tolerated, it will be great. If it's not tolerated, the baby will stop, or we will stop introducing milk, wait for several months, and then try again. If he tolerated the pancake, which has a baked milk, we can start moving to less baked, but more amount of fresh one, like in cheese. And then we will move to yogurt, which is less well-cooked dairy products, until at step 6, we can reach suitable infant formula. By that, I reached the end of my presentations. Thank you for listening. And if you have any questions, please let me know. Thank you and have a nice day.
How can we do weaning with AAF as taste acceptance is not well tolerated?
Usually as early as you start introducing, because I cannot see the question. So the question is, babies do not like the amino acid formula. The earlier you start introducing it, the better the tolerance would be. And if it's not in a severe reactions, sometimes we start with extensively hydrolyzed formula because it has a better taste, and then we start mixing it slowly until the baby gets used to the amino acid based formula. But this is for non-severe reactions. But I'm telling you, if you start early, the tolerance would be much better. Whatever you postpone it, the tolerance will be worse.
Failed oral immunotherapy, do I try again after a period of time?
Until now, the oral immunotherapy, it still needs more studies and still under the studying process, and it's not really a good thing to follow. So the last SPGN recommendation is still to wait until it is a proven way of doing it. So maybe Dr. Hudud would have more answers to that.
Is there any study supporting using vegetables in the first year of age?
Using vegetables?
Yes.
Definitely. If you look into my slides, you would find all the recommendations. Vegetables should start from 4 months of age.
Okay.
So if you go to my my slides, you would find all the references there. And if you look into the American Dietetic Association, also their references is there. The American Pediatric Association is there.
Can you please make more focus on milk ladder?
Okay, I'll explain. You want me to explain it again? Milk ladder is looking into the reintroduction of milk into the infant diet after he reached 12 months of age. Usually it is used with non-IgE mediated cow milk allergy. They start with biscuits or cookies, which have very small amount of baked milk protein, because when you do a cookie or a biscuit, you don't need a lot of milk and you use butter only. So if the baby tolerated this biscuit, after a few days, or maybe a week, they will start introducing a more baked milk. If you remember the slide before, I said that studies showed that baked milk is better tolerated than the fresh milk. So we will start with baked, very small amount of milk protein. If tolerated, if the baby tolerated the biscuit, we will move the next step, which is muffin. The muffin would have more baked milk, okay? So if the baby is able to tolerate that, after 1 week, we will start with small amounts, like at the beginning, a quarter of a biscuit, and then you will make it a half, and then a whole, and then with the muffin, you will do the same. And after the muffin, you would move to the pancake, because pancake, I'm just giving examples. Pancake would have more baked milk. So if he's able to tolerate that amount, that is very good. And then you would move like that. If you reach the pancake and he start having symptoms, you will stop for sometimes and then try again later, like after a month. I have from my experience from my daughter, she used to have cow milk allergy. At 12 months, I tried reintroducing milk and she started having severe reactions. When she reached 18 months, I tried again with very small amount daily and she was able to tolerate after like 2 weeks and she was on regular milk since then.
Thank you, Mrs. Abu Saleh, for another insightful session. We would like to take this opportunity to thank both our speakers for their time this evening, and we would like also to thank you all for attending, especially in those uncertain times. A recording of this webinar will be available shortly, and a link will be sent to your email. We would also appreciate your feedback on this session to help us develop and refine future sessions. A link to the feedback form will be sent shortly. Finally, a certificate of attendance will be available and will be sent to the email address used to access this meeting room. We would be hosting another webinar in 2 weeks, the details of which will be communicated in the coming days, so we hope to see you all again soon. Until then, thank you for attending and take care.